So welcome back everyone. We come to a very important part of our annual Frontiers meeting now. Professor Nicholls was one of our esteemed St Mark's surgeons who made an incredible contribution to colorectal surgery during his career. We're very proud of all that he did for us within the hospital and indeed all the work that he's done nationally and internationally. We're also very grateful as he continues to support St Mark's with the annual John Nicholls Prize. So each year, the fellows who are working towards their higher degrees present their work at the St Mark's Grand Rounds, and a winner is chosen. And this year again, the standard was exceptionally high, but there can be only one winner. And I'm delighted this year to introduce Dinh Mai, who won the John Nicholls Prize. So Dinh, we look forward very much to hearing your talk.
Thank you. Okay, so thank you very much, Prof. Hart, for the introduction, and I'd like to thank the Academic Institute for awarding this prize to me. I'm truly humbled. I'm very honoured to present to you all here today, and particularly in the presence of Professor Nicholls himself as well. So I'm a research fellow at St Mark's. This is my final year of research now, and I'm part of the bicycle group, which is led by Mr. Jenkins. So our research group is primarily interested in body composition and its role within disease, and particularly from an angle of how it can be manipulated to improve disease outcomes as well. So my PhD thesis is examining the implications and applications of AI-assisted opportunistic body composition analysis from three-dimensional imaging in colorectal cancer and intestinal disease. Now, that's a bit of a mouthful, and I'm hoping by the end of the talk, things will become a bit clearer. So this presentation will summarize the results of 3 studies that will make up part of my thesis. And I'm hoping it's going to be quite a natural supplement to that fantastic session we've just had on prehabilitation as well. So when I talk of body composition in this presentation, I'm going to be focusing on adipose tissue and skeletal muscle, so at the tissue level. Now, in terms of some key terminology, so as we know, as we've heard, sarcopenia is a syndrome of progressive and generalized loss of muscle, skeletal muscle and strength. Myastheniasis is the phenomenon of fatty infiltration of muscle by adipose tissue, as depicted in Wagyu beef here. Radiodensity is the degree of opacity a tissue displays to X-ray waves. And tissue-level studies have shown that reduced skeletal muscle radiodensity is therefore an indirect measure for myastheniasis. Now, there's a large body of evidence that's summarized in this 2021 meta-analysis, which shows that sarcopenia is an independent predictor of reduced overall survival and reduced disease-free survival within colorectal cancer. And one of the included studies was actually published by our first bicycle fellow, George Malitsius, who I think is here in the conference somewhere. Similarly, myastheniasis also is an independent predictor of overall survival and poorer cancer-specific survival in colorectal cancer, but not disease-free survival. When it comes to excess adipose tissue, or adiposity as it's known, this meta-analysis in 2022 last year concluded that they didn't identify any significant links between excess visceral, subcutaneous, or total adipose tissue and colorectal cancer survival. But what about rectal cancers requiring beyond TME resection, or locally recurrent rectal cancers? The body of evidence in this field is smaller, so the largest sample size study published looking at pelvic exenteration concluded that whilst there was a significant relationship between myastheniasis and reduced overall survival after pelvic exenteration, this was not independent on multivariate analysis. Now, in order to measure body composition from CT scans, it requires a process termed segmentation. So segmentation is simply the labeling of each individual CT pixel according to a category. So in a non-clinical context, this could be tiger versus savanna. In a clinical CT scan, this could be visceral adipose tissue versus skeletal muscle. Now, the aforementioned studies have used segmentation of skeletal muscle and adipose tissue taken from the surface area only of a single axial CT slice, usually taken at the L3 vertebra. And this single slice is representative of the total body composition. And that's been the de facto method for measuring body composition within cancer cohorts for the past 2 decades. Now, technology's progressed, so deep learning neural networks are a subset of artificial intelligence, and what this essentially allows us to do is automatically segment and quantify skeletal muscle and adipose tissue from CT scans. And more recently, this can now be performed beyond just a single slice level to extend to the entire multi-slice CT scan. Now, my first study that I've published from my thesis was a systematic review looking at the automated methods of 3-dimensional body composition analysis from CT. And one of the algorithms included is now actually a commercially available software. So the Data Analysis Facilitation Suite, also known as DAFS, is a deep learning-driven software that automatically will quantify skeletal muscle, subcutaneous, visceral adipose tissue, as well as bones and organs. And it will do this not just for a single CT slice, but for the entire 3-dimensional scan as depicted in this video. And our group is fortunate to be working in collaboration with the AI engineers behind this technology. They're based in Simon Fraser University in Vancouver. So instead of just getting the body composition of a snippet of the entire body, we now can get a much more extended and richer body composition profile from the clinical scans that we already perform for our cancer patients. In addition to this allows us to look beyond the abdomen. It allows us to look specifically at the thoracic body composition. Even more specifically, DAFS will quantify the epicardial adipose tissue. So this adipose tissue uniquely lies in direct contact with the cardiac myocardium, as well as the coronary vessels itself. And it's thought to therefore have both an associative and a causative link with certain cardiac diseases, and we'll revisit this concept later. So the aims of the studies described in this presentation, the first aim was to externally validate DAFS to ensure that we were satisfied it could accurately measure body composition from the CTs that we have at St. Mark's. Following that, we wanted to use DAFS to examine the 3-dimensional body composition in patients undergoing resections for primary non-complex colorectal cancer. So that's the first cohort. And then the second cohort we wanted to examine were patients undergoing resection of complex rectal cancers. Now, within the second category, there's 2 subgroups. So we looked at primary locally advanced rectal cancers requiring beyond TME resection. And we also looked at locally recurrent tumors as well. Following that, we wanted to look at the interplay between the volumetric body composition measured and its relationship with overall and disease-free survival. And we also wanted to look at post-operative outcomes as well, post-operative complications in particular. Now, in terms of databases, the non-complex colorectal cancer resections ran from 2006 to 2013. The complex rectal cancer resection database ran from 2009 to 2021. We included all patients who had a staging preoperative CT scan at least covering the abdomen and pelvis within 2 months prior to surgery. For the complex rectal cancer patients, we also looked at their thoracic CT scans. Now, DAFS then segmented the skeletal muscle, subcutaneous and visceral adipose tissue, and it did so for the abdominal pelvic region, which we defined as being between L1 and the inferior coccyx. DAFS then produced volumes and radiodensity for all 3 of these tissues. The volumes particularly were then corrected for patient size. Everything was then converted into sex-specific quartiles and tertiles. In particular for the skeletal muscle, we also used literature-specific cutoffs as well. For the thoracic CT scans, we followed a similar pipeline, with the exception now that the region of interest was between T2 and T11, and epicardial adipose tissue now replaced visceral adipose tissue. I'll be brief with summarizing the results of the validation study, but essentially these Bland-Altman plots show that there was strong agreement between the clinician-verified volumes of skeletal muscle and adipose tissue versus the automatically produced volumes by DAFS. And figure 2 also shows that the mean differences in all of these tissue measurements were also very low. So having satisfied ourselves that DAFS was accurate for our cohort, We then firstly examined the primary non-complex colorectal cancer resections. There were a total of 750 patients with a median follow-up approaching 5 years. So in terms of overall survival, we performed univariate and multivariate Cox regression analysis, and we found that sarcopenia, myastheatosis, reduced total adipose tissue index, these three things predicted poorer overall survival. In addition to this, how bright the fat looked also appeared to be significant. So patients with elevated subcutaneous or visceral adipose tissue radiodensity, these patients also had a poorer overall survival. And all these factors were independent of age, ASA, tumor stage, grade, and lymphovascular invasion. In terms of recurrence was predicted by sarcopenia, but interestingly, it was also predicted by elevated visceral adipose tissue radiodensity. And again, this was independent of stage, grade, and lymphovascular invasion. The key finding here was that patients in the highest quartile of visceral adipose tissue radiodensity, they had a significantly increased risk of both mortality and recurrence. We did a subgroup analysis on these patients. So patients in the highest quartile of visceral adipose tissue radiodensity, they were likelier to be female, likelier to have a lower BMI, and likelier to have T4 disease or lymphovascular invasion. Now, moving on to the complex rectal cancer patients, out of the 364 patients that were included, 2/3 were male. It was a fit population with 85% of patients being ASA 1 or 2. 2/3 of the patients were primary locally advanced rectal cancers undergoing beyond TME resection. And in terms of operative types, 87% of these patients underwent some form of exenterative surgery in the pelvis, and 1/3 of them also required a sacrectomy. The R0 resection rate was 86%. Now, looking specifically at the primary locally advanced rectal cancers, there were 240 patients, and on univariate and multivariate analysis, myastheatosis significantly independently predicted poorer overall survival in these patients. And this was independent of age, ASA, stage, grade, vascular invasion or perineural invasion, and resection margin positivity as well. There were no body composition predictors of recurrence in the beyond TME resection group. And as for the locally recurrent rectal cancers, there were only 124 patients, but we couldn't find any body composition determinants of survival or recurrence. Now, looking at the 90-day postoperative outcomes, we recombined both groups, and we looked at 90-day deaths, major complications, collections, cardiovascular complications, and central nervous system complications. Now, on univariate analysis, we found that patients with an elevated epicardial adipose tissue quantity, they appeared to be at a higher risk of getting 90-day cardiovascular complications as well. Upon multivariate logistic regression analysis, we found that this effect was again independent. So patients in the highest tertile of epicardial adipose tissue quantity, they had an independently increased risk of cardiovascular events in 90 days, and this was independent even of known cardiovascular disease before the operation. So, in conclusion, when looking at the primary non-complex colorectal cancers, in addition to what we already know about sarcopenia and myastheatosis, the key findings appear to be in the fat. So firstly, patients with reduced total adipose tissue quantity, they had an increased overall mortality. This could simply just be a snapshot of the patients who are undergoing cancer cachexia from more aggressive tumor biology. What's more interesting, I think, is that patients with elevated visceral adipose tissue radiodensity, not only were they at risk of increased mortality, but also of tumor recurrence. And I think whilst further validation is required, this could be a new prognostic marker within colorectal cancer postoperatively. And not only that, it was also associated with a more aggressive tumor phenotype. When it comes to the complex rectal cancer patients, so the patients who had locally advanced rectal cancer, this is the first study to show that myastheatosis independently predicts overall survival post beyond TME resection. And the key thing we have here is we've got an independent determinant of outcome that's actually modifiable. So this meta-analysis published in 2021 on non-cancer patients, it concluded that a combination of strength training regimes and aerobic training can actually improve patients who are myosteatotic. So it can actually improve their skeletal muscle radiodensity upon CT. So I think following on from the prehab talk, I think there's a strong need for a study that will look at targeted prehabilitation for myosteatotic patients undergoing beyond TME surgery and see if by treating their myosteatosis that actually improves their overall survival. Moving on to epicardial adipose tissue and increased post-operative cardiovascular events. This is in line with research that was published this year. So there's a big meta-analysis published this year which concluded in non-colorectal cancer patients that elevated epicardial adipose tissue quantity independently was associated with cardiac events, cardiac death, atrial fibrillation, and MI. So this could be a very useful perioperative predictor of outcome, and it could help us stratify patients who need cardiology workup preoperatively. And I think the final point I want to end on is the other thing these studies show is that clinical imaging is full of information that is beyond traditional radiological interpretation. And I think the new era of AI could continue to unlock these as well. None of this work would be possible without the people listed here. In particular, I'd like to thank Mr. Jenkins and Professor Athanasiou of Imperial College, who are my supervisors. The Bicycle Fellows, both current and past, Joanna, Toby, Laura, Jason, and George. My work would not be possible without them. I'm truly standing on the shoulders of giants. The St. Mark's radiologists, in particular Phil Lung and Tom Glover, and our collaborators over at Voronoi, Uni of Westminster, and the myeloma team at UCLH, who are involved with some of our other projects. And I'd like to thank you all for listening.
Thank you very much indeed, and fascinating data and really clearly presented.
Thank you.
John, anything you'd like to say? Or
No, Din, that was an amazing study, which I'm sure will go right into the future as creating or contributing to clinical practice. Beautifully delivered, and the work you put in there and the collaboration that you managed to establish are all extremely notable. We're very lucky to have heard it. So it's my great pleasure in giving you the, well, it's not giving you the prize.